Um, my talk is on cognition and behavior and how they influence the course of illness of MS, and also what we should be thinking about in terms of management as a consequence. Start with presenting a patient just to understand the kind of problems that we see in people. This was a 40-year-old gentleman who had a 4-year history of MS and had been on beta interferon treatment elsewhere. He came with complaints of periodic worsening of symptoms. So his problems were episodic, and each time he had mood changes, increased anxiety and panic, and he had cognitive dysfunction. And while he feared that every one of these episodes was an actual new episode of MS as well, there was no documented cerebral change that had been found with these new episodes in his case. He was seen by a neuropsychologist, and the main complaints he reported to her were low self-esteem, anger outbursts, disharmony in his marital life, increased speech. He was very verbose, increased libido. He had a problem of hypersexuality. He had mild memory issues, and he had difficulty with coordination and balance. And he had a 4-year history at that time of MS, and he had not had any new lesions for about a year. When she examined him on the frontal lobe tasks, he had difficulty with ideational fluency, he had difficulty with motor tasks, and on block design, he had difficulty with implicit designs. He had apraxia but no agnosias, and he had mild problems with left temporal lobe tasks as well as right temporal lobe tasks. But she interpreted the right temporal lobe difficulties as being due to encoding, and therefore more an attentional issue than a true problem of memory. His Rorschach test, which is a test of personality structure, indicated organicity. He preferred isolation, was caught up with defendants, there was a superego conflict, he had self-esteem issues, and he was rebellious. So she recommended to him that he should have supportive therapy, marital therapy, and cognitive rehabilitation, and that's what he proceeded to have. Now, some of his problems are actually quite typical to people with MS. Sexual dysfunction is considerable, but it need not always be low sexual interest or lack of sexual activity. It can also be hypersexuality, and I think that's what this particular gentleman points out to us. Disinhibition is a very common symptom of people who have frontal lobe dysfunction, and disinhibition in MS is a particular problem, and we'll talk about a syndrome of disinhibition as we go along. He complained of uncontrollable laughter and crying, which again can be extremely embarrassing for a person in a social context or in an occupational context. It often accompanies a heightening of emotions. He had temper tantrums, he had mood swings, he was impulsive, and he had changed his job 4 times in the last 2 years, and he was currently out of work. And I think that kind of defines how difficult cognition and behavior and the problems thereof can be in living with the condition. He was observed to have episodes of panic, and during these episodes of panic, as we followed him, he would complain of a worsening of neurological symptoms. To give you a particular example, this man would complain of worsening of gait every time he went into an episode of panic, and it was very difficult to be sure whether there was a real worsening of gait or whether this was simply gait disability due to a kind of phobic anxiety that he was manifesting each time. He was observed to have more panic episodes during his depressive phases, and he seemed to be better when he was euphoric. So he had mood swings, and he would be better sometimes perhaps too well, too confident, and at other times he would be clearly depressed. So he was treated with counseling, cognitive behavior therapy, cognitive retraining. His wife was counseled, they were spoken to together, and so on. He also received physical and occupational therapy for gait, for balance, and for fine motor skills, all of which were important for him. Overall, he got better with the interventions. He started functioning better. He had fewer exacerbations of panic. But before he migrated abroad, which was the last time we saw him, he once again came with gait difficulty, which for the first 24 hours we thought was part of his panic syndrome. But on this occasion, when we repeated the MRI, it did actually show new lesions. So we nearly got caught by a wolf-wolf kind of syndrome. And this also, in a sense, the reason we took this gait disability seriously and repeated the MRI, apart from the neurological signs on examination, was that we had actually dropped his dose of beta interferon because he'd been so well for about a year. And the gait disability accompanied that change in dosage. And one of the important reasons to change the dosage was because he was finding the frequency that he was taking the beta interferon was too expensive. He could not afford it. So he wanted to stop. And we said, don't stop, try reducing. And then he had this worsening. So what does the literature tell us? There is a uniform pattern, and primary language functions, immediate and implicit memory, and verbal skills, intellectual skills in particular, appear to be quite unaffected in MS through much of the course of the disease. Information processing abilities, complex visuospatial tasks, conceptual reasoning, and sustained attention, however, seem to be affected, as well as working memory deficits and retrieval functions and executive functions often seem to be affected. The severity of cognitive impairment often correlates with the physical disability. It also correlates with the severity of depression. And I think that this is important in the sense that there is a concordance between how physically disabled the person is, how the person is feeling, and the level of cognitive disability that they are experiencing. Males appear to be especially vulnerable. Childhood and juvenile cases are also associated with low IQ scores and overall general impairment, and those with a longer disease duration appear to have the greatest risk of cognitive dysfunction. The slowing of information processing is something that is pervasive, and when you test people with MS over time, they are sometimes as much as 40% less than their controls. So they take 40% time longer to process information than somebody there, comparable to them who does not have MS. The other interesting thing about cognitive dysfunction is that it's fatigable. In other words, you keep testing a person, have a prolonged test, the longer you go, the more dysfunction seems to manifest. And that is quite unique to this condition, because usually cognitive disability in most other conditions is kind of stable and does not change like that. Secondary progressive patients with MS are more affected than those who are primary progressive, and relapsing remitting individuals appear to be least affected. And what has been described is a multiple disconnection syndrome to describe the diversity of neuropsychological deficits that we see in MS. And of course, most disconnection syndromes are unique in the sense that they do lay the framework for multi-domain cognitive impairment. So the cognitive impairment is not in any particular domain. And what's also interesting is that, like in dementia, cognitive reserve appears to play a role. So people with a greater lifetime of intellectual enrichment appear to take longer to manifest their cognitive dysfunction and are less disabled by the cognitive deficits. And I think that we see this in various forms of dementia as well, that if you have a lifetime of intellectual enrichment, you actually do better and it takes you longer. We call it a cognitive reserve. Psychiatric disorders are more prevalent in MS than in healthy controls. They are more prevalent even when compared to other chronic health conditions. So it's not just with normal controls, but also with other disease controls. And many patients either manifest with psychiatric symptoms or present with them during the course of the illness. Depression is perhaps the most common, but bipolar disorder, pseudobulbar affect, and anxiety have all been reported in this population. Depression is particularly important because the lifetime risk appears to be greater than 50% in people with multiple sclerosis. And it's historically thought to be reactive. It's thought to be a reactive depression to the having such an illness or the disability that the illness seems to confer on the person. There is also evidence that other factors such as unemployment play a role in perpetuating depression. And of course, epidemiological studies show that the severity of disease and lack of social support are associated with depression. But depression in studies, MRI studies, have been linked with frontotemporal lesions, which is understandable, and or ventricular enlargement. It has been linked with immune and endocrine dysregulation. Fatigue and depression seem to go hand in hand, as well as somatic complaints and sleep disturbance. And working memory deficits and cognitive dysfunction also, as I mentioned, appear to be associated with depression. People with a previous history of depression or a family history of depression appear to be more at risk. There are psychosocial stress, and social support systems are obviously an important factor. And unrealistic expectations of treatment and outcome perhaps play a role in how people feel about how people feel and what their emotions are like. The Goldman Consensus Conference recommended that regular screening with tools like the Beck Depression Inventory is important for all those who are on long-term follow-up for multiple sclerosis. And active assessment of all those who screen positive in these tools has been recommended, and also those who make any suicide type inquiries, because acute worsening of MS can actually result sometimes in people reporting feelings of not wanting to go on, or feelings that they can't cope with the worsening of the illness. It's recommended that treatment plans are individualized, and that there's a role for drugs, there's a role for psychotherapeutic interventions, and there's a role for combining these different interventions. And it's also recommended that there are standardized therapeutic algorithms that need to be developed. Depression has been documented early in beta interferon treatment, but not in long-term follow-up, and therefore there seems to be a link between outcome from treatment and with regard to lower disability as well. And it's been shown that subcutaneous interferon beta 1b has beneficial effects on moods, and not shown to be associated with any increase in depression. Interferon beta 1a was linked to depression in early studies, but larger beta studies have not shown any association. So, in general, studies don't appear to support a link between any specific treatment and depression in MS, but pre-treatment depression, especially when it's associated with disability, may have a role, and treatment may sometimes actually lead to an improvement in depression. Of course, we know that drugs used in MS, frequently like corticosteroids and oxybutynin, can have an impact on mood and psychotic symptoms. We also know that drugs like baclofen and tizanidine used for spasticity have a propensity to make confusion worse or to cause psychotic symptoms in those who are so prone. Another important clinical symptom in people with MS is anxiety. About a quarter of all patients have reported anxiety, and it's not been found to be specifically associated with any brain lesions. However, it has been reported to be linked with psychological response to disease. One of the important features that neurologists often comment about, of course, is the pseudobulbar effect, or the pseudobulbar, what we call pseudobulbar palsy. But pathological laughter and crying have long been associated with multiple sclerosis and are now referred to as involuntary emotional expression disorder, IEED. It's estimated to affect about 10% of all patients. It's often mistaken for depression or bipolar symptoms. And in a study of 152 patients, IEED was found to occur in patients with long-standing disease and severe physical disability, cognitive dysfunction, and bilateral lesions, and was not observed to be associated with the occurrence of clinical exacerbations. Disinhibition is part of the IEED syndrome and has been called emotional incontinence, pathological emotionalism, or pseudobulbar affect. And the postulated cause is the disconnection of frontal lobe control from limbic brain regions. And there are in neuropsychology, there are actually two theories in terms of direction. Luria actually thought about this very differently. Some people feel the commonly held view is that it's the loss of frontal control. But what Luria postulated was that it was an increase of limbic outflow, which was not regulated by the frontal lobe, that really caused people to lose control over their emotions. The clinical features of disinhibition, at the baseline, emotions are normal. When there is an episode, emotional responses are hair trigger or excessive. So the same stimulus appears to make the person with disinhibition react much more significantly than the average person. So it's a normal or an appropriate stimulus can cause an extreme response in someone who is disinhibited. Interestingly, and I think it's worthwhile pointing out that while we talk about disinhibition in MS, the frequency of IEED in MS is much lower than some other conditions like traumatic brain injury, dementia, and stroke. So essentially, it is more a feature of diffuse brain injury than it is of a particular disease. And I think that this is something that is worthwhile keeping in mind. It's quite effectively treated by a range of drugs, starting with the conventional drugs like amitriptyline and nortriptyline, the TCAs, to the SSRIs. All these drugs appear to have some impact on the involuntary emotional expression disorder and to help control emotion in all these patients. There is no approved treatment, but most people are on antidepressants or dopaminergic agents. Combination treatment may be involving dextromethorphan and quinidine may offer a novel strategy, but I don't think this has been very well validated. The psychological interventions for MS, randomized controlled trials are limited, and I think this is a problem with a lot of psychiatric non-pharmacological treatment, is that it's very difficult, in fact, to carry out a randomized, blinded, controlled trial because the treatments are not amenable really to fit into that paradigm. So the available data are not very conclusive, but what seems to be evident that structured psychotherapeutic approaches, like for example cognitive behavior therapy, do have a role to play in the long-term management of MS and of cognitive dysfunction in MS and of behavioral dysfunction in MS. So of the drug treatments, because of side effect profiles, the SSRIs are more preferred than the tricyclic antidepressants. For fatigue, amantadine and modafinil may have a role to play. For bipolar symptoms, carbamazepine and lamotrigine have been preferred over lithium in this population, and atypical antipsychotics like olanzapine may have a role to play. Olanzapine, as you know, and some of the other atypical antipsychotics are today on a watch because they do cause metabolic syndrome, they do make diabetes worse. So if you have MS with comorbidity, then you ought to be a little cautious with those drugs. Anxiety gets better with the SSRIs like paroxetine, sertraline and escitalopram, and it is generally accepted, and a meta-analysis has shown that the combination of drug and psychological treatment is superior to either one alone. So to conclude, I think it's important to say that both cognition and behavior are affected in multiple sclerosis. They mirror one another, so they feed off one another, that they also are affected by physical disability, which also needs to be addressed. The treatment of the MS per se is important, but along with that, the treatment of these comorbid symptoms is important. Both pharmacological and non-pharmacological interventions have a role, and here I might want to just add to the debate that was going on earlier. I think it's important to keep in mind that the acceptance of and interest in alternative treatments has grown considerably worldwide, and it has grown in countries like India as well. You'll be surprised to know that the nutraceutical industry today is globally larger than the pharmaceutical industry. It's many more $1 billion than the pharmaceutical industry is. And that's a very interesting statistic. It tells you that people are reaching out for other things. The nutraceutical industry, one of the criticisms, of course, it's unregulated. You can take something off a supermarket shelf. But having said that, people seem to be taking whatever is offered off the supermarket shelf. So I think it's important to keep in mind that we have to balance what we accept as scientific with what people seem to be interested in, because the consumer, the person with MS, the stakeholder really is important, and their wishes matter. The other additional point I'd like to make, I think the point about hypnosis was well taken, but I'd also like to point out that many Indian systems perhaps have a lot to offer which have not been explored. So I'm not suggesting we use those systems without studying the effects properly, but I would also say that we should not close our minds to what alternative systems may have to offer in terms of living with long-term illness and disability. And I think the word counseling is often thought as giving people advice. It's not. Counseling is sharing accurate information. And I think that anyone living with a long-standing illness needs to have the opportunity to share information accurately. And I think that that is perhaps what's often lacking with long-standing illnesses when we look at it in different segments. And finally, with regard to this talk, I think we ought to be sensitive to the fact that living with long-standing illness does cause problems with emotion. In this particular illness, it also causes problems with memory and with other higher brain functions, cognitive functions, and they need to be screened for, therefore, adequately so that we actually do not miss them. They can, if we don't watch out for them, turn out to be an invisible disability, because you don't actually, unlike the physical disability, you don't actually see this form of disability until sometimes it's far too advanced. So with those comments, I will stop there. Thank you.